Right, so welcome everybody to session 3 of CHCCCS014, Provide Brief Interventions. Just do our acknowledgement of country. So in the spirit of reconciliation, Hayter Institute of Education acknowledges the traditional custodians of country throughout Australia and their connections to land, sea and community. We recognise Aboriginal and Torres Strait Islander people as the first inhabitants of this nation and the traditional custodians of the land on which we work, live and study. We express our gratitude for the sharing of this land, our sorrow for the personal, spiritual and cultural costs of that sharing, and hope that we may move forward together in harmony and in the spirit of healing. We pay our respects to all First Nations people and acknowledge elders past, present and emerging. So welcome everybody. Just a little bit of housekeeping. Cameras on, mics off whilst we're presenting. And you can use your hand emoji to ask questions. We have what we call respectful language here. So that's our duty of care. So as you're all emerging practitioners, as I like to call it, in some sort of industry within the sector, it's being mindful about what we're saying, how we're saying it, how we're including people, and how we are being respectful of the actual language we're using, and making sure that we are listening to our peers and contributing as well. There's no smoking or vaping on screen. Some of the content could cause an emotional reaction, and this is where you can reach out for support, especially with people that you know, and also to using Lifeline on 131114. Now, Lifeline's not just for crisis intervention. Lifeline's also a great resource to talk to somebody from a non-judgmental background, that they're there just to listen and support as well. So we have many of our learners who use that from study stress. So it was quite interesting to hear somebody's experience around, they just wanted to talk to somebody. All these thoughts were going on in their head, but they weren't in a crisis mode. So they did ring, and they had a really good experience being able to just talk to somebody and get that out. This time of year, there's lots of illnesses happening, so please look after yourself. Take that time to ensure that you nourish yourself and feel well. Now, also too, before we move ahead, just to let you know that there's new classroom etiquette around using chat. So chat will be used when we're not recording, and we can also use that in our breakout rooms as well. But because there was content that people could not follow from recordings, who learn in the background, who don't come to class, who can't come, they were losing context of what was happening. So what they've asked is that we only use chat when we're not recording. And other than that, we'll use breakout rooms to communicate with your peers. All righty. So tonight we're looking at that referral process. We're looking, how do we offer that support? What sort of areas will we be referring to? What documentation do we need to support that? And what meets the law around our service provision? So let's go straight into from where you were last week, learning around the steps of change and where we were walking into pre-contemplation and contemplating. So where somebody's really not ready to change, just starting to think about, I can't keep doing what I'm doing, but I'm not sure where to go or what to do. So they're contemplating, they're on the cusp of changing over, and then they will go into a motion of actually acting out and seeking support and committing to support. That's a big part of it, committing to the actual support and maintaining that. Now, once you're maintaining that, you're gathering your support, your strategies, and you as a worker in that sector would be encouraging somebody to stay with that recovery pace and moving forward and keep updating those strategies of what's working well for them and trying to create less barriers as well. But life happens, and a relapse or a lapse, as we call it, can often happen. Now, they're a little bit different in the term. A lot of people use relapse as one whole thing. I've seen this in play, and a lapse is quite different to a relapse. And a lapse can be where somebody might have taken, for a recovering alcoholic, taken one drink and not used any more and gone, no, I can't do this. I've got to get back onto my maintenance practices. When somebody's relapsed, they've often taken part in a full-on intake of drugs or alcohol at the level they were using how long ago before they stopped. So if they've not been using for 3 months and they were continuously using so much per day, they've had a 3-month break. They've gone and had a life event, an upheaval, an upset, something that's taken them away from their recovery, and emotionally it's upset them. So they've gone straight into using the amount they used when they were at their highest usage 3 months ago. That can actually cause them to go into overdose because their body has not had it for 3 months. Then the next day, that urge and need is so strong, they've kept it up. So they've returned back to where they were. They might then come through and then go, whoa, I've just blown all of that by doing what I've done, and I want to get back to maintenance. No, we need to go back to the processes again. Start from the beginning. Start those processes again. Lapse is easier to jump back in to maintenance stage. And the different concepts, because relapse is a long-term behavior that's reignited. And that's something that once that button is switched for some people, they feel like the euphoria, the high, and then they'll get that low. And that's when they might say, I don't want to do this. I want to go back to my recovery goals. But the degree of substance that's used and how long they've done it for can often vary how they stop during those occurrences. So, and relapse is often, and lapse is often something that is expected in this stage as well, in the maintenance stage, because it's not about a person about being weak or giving up. It's about something that's happened and they've not yet learned the strategies to deal with an emotional change or a challenge or a stress. And those practices of using alcohol and other drugs as soothing are quite ingrained when they've done it for quite a long time. So coming out of that and away from that, learning new strategies to replace those go-tos, that's the key to keeping the recovery process. But understanding as workers that a lapse and a relapse lapse in much shorter time, and often the behavior you've gone back to can be viewed by that person enough to go, I know those behaviors, I don't want to do that. I don't want to go there again. Whereas the relapse can often take people down that spike so deeply before they're willing to give that up and come back to that. And it's very personal when that happens too. And because the body's saying one thing, the brain's asking you for something else because of all the effects of what's going on. So this is an internal struggle that's happening for someone. And for many reasons, the challenges rise. The dependency's being triggered. That dependency stays there. Your dependency on that. That's why it's recovery, in recovery mode for a long period. I was speaking to one of our other learners in another class who has done the 12 steps program with AA for 10 years. And they said they know they can't touch alcohol. It's like a disease for them that having one is enough to throw them back. So he said that very carefully. His practices have been that he talks to somebody daily. He talks to other peers as well, because they're like, they do that coaching with each other. But he said it's a continual practice of daily being grateful, moving forward, understanding your strategies are working towards something, but not going back for just one, because that is dangerous for themselves, as he was saying. And that danger point is even contemplating going there, reaching out and getting support, even thinking about that. You as a support worker, a caseworker, to understand when somebody reached out and said, I just want to talk because otherwise I'm going to have a drink or do something. It's crucial to keep that person talking at that stage. Any questions? Right. So we talk about some of the reasons, and there is many life reasons why this would happen. And the guilt that somebody feels because that's happened, it's an internal conflict, and a guilt can happen. I've let myself down. I've let my family down. I've let my friends down. I let my support worker down, my case manager who's working with me. I've suddenly just blown my coping mechanism. You haven't. You've just gone over a wave and dived down, but you're going to come back up. And we can turn that back into, get back onto that train of practices. Understanding what reasons people will have, and there's so many. It's quite important here in the community services, whether you're working in AOD or not. It is around understanding what those triggers could be for anybody. You could be working in housing and you have somebody who comes in and says that I've been addicted to drugs for a while now, and they might be getting support, but it's understanding those behaviors that happen that could affect service. A lot of people might turn to this because they're caught up in an unhealthy relationship, financial stress, loss of job. But understanding why lapses happen is all part of the cycle of it. So let me just pause here. We're going to go into breakout rooms. All right, welcome back, everyone. So let's have a look at reasons people feel that could be due to what could cause a relapse or a lapse. So room 1, Bella, Patience, and Tanika. What did you come up with as a group?
Sorry, I'll pop in there and then see you later. But we're talking about relapse is something that like you get to go back to things that you used to do, like a drinking or smoking, because something happened, or you get into a certain situation and you get frustrated, and at the end of the day you don't get what you wanted to get, and it gave you frustration, and you begin to, like, say for example, if you used to drink or smoke, because you get frustrated, you don't know what to do, it takes you
Yeah.
backward, and you begin to go back to your habit, like the past habit.
Yeah.
Yeah. So
And was there one certain thing that could trigger something off like that, like
yeah,
events that you could think of?
yes, yeah. Sometimes, like if you are, let's say, it come to maybe jobs, you lost your job, or um, you come to a family situation around you, or maybe like something get you frustrated. So
Sorry, Patience. I'm just gonna hold you there. Somebody's
yeah, I think someone's
just trying
sleeping.
to see what's happening here.
Sorry.
I think we might have sorted that out. Sorry.
It's okay. Uh,
So, yeah, so lots of jobs, something that's really become a crisis for somebody.
Yeah, it's like something become a crisis, or maybe a relative is sick, or you lost your job, or circumstances come around you and you get frustrated and stuff like that.
Yeah.
So, yeah.
Thank you.
Yeah.
All right, room 2, Danny, David, and Sarah. What did you come up with?
Okay. The first one was the issue of situations that tempt the person to return to drug use, and this could be life events,
Yep.
maybe the loss of a loved one, stressful situations, attending parties where you're gonna meet people that you usually use drugs with.
Yep.
And celebrations, let's say you get a new job or you get money, then you just feel like celebrating. During the celebrations, you're tempted to use drugs. And then we also talked about family associations, um, maybe your family, you as members that use drugs as well. So now if
Yes.
you stop using, now they start stigmatizing you, saying you think you're better than us because you're no longer using, you don't want to use drugs. And then in the end, you end up relapsing, going back to the drug use because you want to have a sense of belonging with your family.
Yes. Yeah.
And
Yeah.
also,
Definitely.
yeah, and relationship breakups. We also mentioned that one, and then pre-existing mental health or emotional issues. We mentioned that self-medication, one may end up self-medicating because maybe they can't find the medication that they usually use for their treatment of their mental health or emotional issues. And then they end up getting back to what they are used to, which is drugs.
Yeah.
Or they may end up overusing the medication that they usually get for treatment, and it ends up
Yes.
being
And then it becomes an overdose.
yes, and
Yeah.
also pre-existing health issues could also lead
Yeah.
to someone having a relapse. For example, if they get an injury and they end up being laid off and they no longer have any activities to do, recreational
Mm.
activities to do, and they end up to get over the boredom, they end up using drugs.
And that's a good point there around. So if they've lost work, for instance, they can't afford then their therapy, so to speak, which would cost, quite a deal of money, but being able to afford something a little bit less to self-soothe is have something very quickly people jump back into because that's the quickest thing
Yes.
solution. And really good association here around that stigma. If you don't do what your social group is doing, how you get stigmatized and left out. And it happens quite often because there can be a drinking culture of a group going to the pubs Friday night, going to the pub after the game, all that sort of thing. It becomes quite a dangerous zone for people to be able to enter to when they're trying to work on the recovery. Some good points there. Thank you.
Oh.
Room 3. John, Sean, Christine, and Kavita.
Okay, well, I'll talk, Helen. I don't
Yep.
know if you kind of answered the question very well, to be honest with you, but all of those are obviously very correct. But I just discussed a situation where I have a friend who works for the Department of Communities and Justice, and another friend who works for the drug court. I think I might have told you that before. And anyway, another friend who she was talking about the fact that her ex-husband's nephew came out of prison. He was a drug dealer, pretty involved in the drug gangland situation here in Sydney, came out of prison having been clean for quite some time. I don't know how long he was in, but it was definitely over a year anyway. And he came out, he went back on the drugs at the same rate, and he OD'd and died. And it was a very sad situation. And the person who's the parole officer, she says, yeah, she says, I know him, and they're warned the whole time that their system just won't be able to deal with it. And then Kavita told another very sad story back in Singapore about her uncle, who again continued to relapse. And it got to the point where he was abusive in the home environment. They had him in the home. It was a danger to the kids, and they had to throw him out because it was just, it was a situation that was untenable with the kids. And then he ended up ODing. So yeah, I don't know if this is particularly helpful.
Yeah,
But I mean, these are very sad situations of relapses and whatever.
Yes, yes, yes.
And
So
you know what Kavita's situation with the story was is that he was just continually kind of, you know, relapsing again and again and again. Yeah. So sad. And the other thing was you know, you talk about rehab and going into rehab. I have a friend whose niece has been through rehab now multiple times. But unfortunately, one of the rehab centers that she's been through, I mean, I don't know, it's happening all the time. She met her buddies in there, you know what I mean? Like kind of so that when they go through rehab, they come out after, I don't know, a month, 2 months, 3 months, whatever. And all her buddies, she connects with them and they all go binging together, you know? It's like,
yeah. So they learnt new skills within a place that
yeah, exactly. That was
Yeah.
supposed to be, you know, like a private rehab, South Pacific private, excuse me. And then they learn how to just, all they're basically doing is connecting with other people that they can go. So I wonder if, like, I know learning from your peers is supposed to be the way to go, but sometimes I kind of wonder, is that really a good environment for them? Because they're just connecting with other people that have fall into the same bad habits, you know?
and it's a real mix going
Yeah.
in. It is a real mix when you do go into a live-in situation. You know, certainly not being able to find those people to support a habit later on is not the aim, but you can't stop people's motives, and you know, you'd want to hope that the benefits of recovery outweigh that, but people will all make their own choices, won't they?
Yeah, I suppose so. I suppose
Yeah.
so.
Yeah.
Yeah.
So thank you. It's a good this is what I wanted this
Yeah.
discussion for, because everybody has different understanding of where people have been, and knowledge of that is really important for us as workers to broaden that view, not sit in with just a life event happened, you know, or somebody had grief and loss and they went that way, or they lost a job. There's so many other issues that happen that are out of the
Mhm.
context, but in the
Mhm.
context of what happens in society. Thank you.
Yeah. Yeah.
Room 4. Mark, Nathan, Vivian, and Haria.
I'll talk for everyone, Helen.
No worries, Mark.
Welcome back to
Thank you.
it. Yeah, I think we've covered a lot of what we've got down here, but probably another one, insecure housing. Do we have that? Yeah.
Yeah.
So people could be out on the street mixing with that same people and same crowd using again. Family history and genetics, I think someone brought up. So I think alcohol is the alcohol gene is passed down through genetics, if I'm right.
Yes. Yes.
I think that's
Can be. Yes.
financial stress, work stress, loss of job. Yeah, and pretty much everything else has been covered. Got down here. I think maybe some people might be in a car accident and get prescribed pain medication, and maybe used, say, pain medication before, and they'll end up relapsing through there. Yeah, I think the opioid
That's
epidemic's pretty bad, Australia
Mm.
and internationally. Yeah.
and
Mm.
a good point there around the major accident seeking pain relief. Often people's pain is not understood enough by the medical profession, or what they're feeling. So people who are very sensory can feel pain so much more. So there's other senses in their brain that are going off as well. And that sensory sensation for some people is so strong that the medication that medical intervention thinks should suffice is not way enough. So there's also the consideration that somebody already might be living with mental health illness, and with the different medications people on, pain relief doesn't work. So the quickest thing is that people will think of is to go seeking drugs that they think are adaptable to pain relief, but it blots out, it doesn't get rid of pain. And that's a huge misconception. But that quick self-soothe, that quick, I need it and I need it now. Understanding that urgency is quite interesting to find out the different levels of how people feel that. Thank you. Where have we got? Yeah, we got Donya and Nathan.
How you going?
Hi, Nathan.
Just for the negative strategies, I've
Mhm.
got judgmental behaviors, so people dragging you down about relapsing and stuff like that, that can really affect people's goals on getting back on track.
Mhm.
Overprotectiveness, so somebody who's hiding somebody from learning to cope with the skills of the relapse.
Yep.
Um,
Not letting them experience anything,
yeah,
keeping them in a bubble. Yeah. Yep.
yeah. If you keep somebody bubbled up for too long and they don't experience life or don't experience certain things, then they go, well, I was kept hidden from all this all my life. Like I've got a mate that his mum never let him listen to certain music, and as soon as he turned 18, he's excessively into different cultures of music and everything now that his mum wouldn't let him listen to. So it's the same thing with everything else. Yeah. Most of the other side, I've got it pretty much exactly what's on the other side, the reasons for lapse and relapse. But yeah, I just wanted to just add a little bit more on this side. That's all.
So what would people see in the sense, we've now got this list. What would people see? Would you look at these these life events and go, there are some everyday things, there are some things that we've not thought about, and depending on the lapse or the relapse, where would you see people going? So like we've heard with post-prison stress, they've gone to a total relapse because of that. Would some of these be in the lapse category, being less invasive into the person, or would you put them all in the relapse stage? So I would look at some of those socializing stigmatizations times where somebody might be pushed to have one drink, and they might have one and then not go back because the social group has pushed that. That's the norm. Got to have a drink. You've got to have a drink. I could see that as being a lapse situation. But then on the other side of it, it could be a relapse, because if everybody else is binge drinking, do they just go into those behaviors? But this is where, for you to determine what somebody's going through to be a lapse or a relapse, is another part of the work here. So it's great work in identifying these. How do we use that knowledge to understand relapse and lapse? So think about that, the degree of something that would happen for somebody. That's what we're looking for, the degree of how that affects somebody and how then they come back to that recovery stage. All right, good work, everyone. So let's look at different types of supports, interventions, strategies, goals that people have, ways of thinking. So we're looking at maintenance here. So maintenance is where we need to have something really good guidelines in place in a recovery plan that are achievable. And it's really important if we're working with somebody on a plan towards recovery, and we could work on plans working people towards recovery, not just in AOD sector as well. This could be around mental health recovery. This could be around somebody's personal health and lifestyle management where they've been in unhealthy relationships and they want to recover and move forward. So there's all different ways to work with this. But the psychological intervention supports are a crucial part of maintaining recovery for someone. So that means going to sessions one-on-one, but also group. And group work's important here because of the peer workers that can be involved, but understanding experiences in different contexts is very good to have. It also keeps people accountable. It's good to celebrate successes in groups as well. So group work's quite good. And when we're talking about when they say here update and support goals, sometimes we're having to ask participants to change their way of doing things. So like we identified before, those social groups that you have, if they're very focused around alcohol and drug use, and it could be the whole Friday, Saturday night thing. We don't do anything during the week, but on the weekends we go hell for leather. That was a very common attitude in Australia from the 90s right through to now, and it's done in a different sense now. But the whole culture around alcohol on the weekends was promoted. It was a part of family life. And all the media, ads on TV were all geared to that. All geared to all sports were governed, had alcohol and cigarettes ads attached to sports. So it was building a culture. And sometimes for people, breaking that culture is different because you're breaking away from traditions in a sense. So having to avoid people and places because you're worried about a trigger, that's hard. So if you know somebody in that situation, do support them. So you're having to think about how else can you be involved with these people, but not at these functions because it's too damaging for you. And it's like I said that a recent learner I was talking to that changed their whole life around doing recovery work in AOD. They found they had to stop going to work functions because of the alcohol. They even went and asked, can we have functions without alcohol? Because there are some people in our organisation who are in recovery. And no, it was part of the culture to celebrate. So they had to find different ways to associate with the same people, but in a different context. And that's hard.
Just put myself off unmute. Can you hear me?
Yeah.
Yeah. I totally agree with you with what you're saying. But I also think that that's a really a linear idea of AOD use. So it's not people that go and drink on the weekends. is people that drink every day.
Mm.
You know, there's people who just overdo it, and then there's
Yeah.
people who can't help but cope. You know, do you know what I mean?
Oh, yeah. That was an example around how to
Yeah.
for
No, I know,
to
I know.
avoid situations, but you are right. People will be in situations where every day in a social context that every day is a struggle for them. It could be their environment they're living in,
Yeah.
the acceptance of that every day. Yeah, you are right. It can be in many different contexts. And this is why we need to open up that thinking. My example was around, it was something that was very well known across the 1990s through to the 2000s and 15s, 20s, that because they then took away that culture of where they had packaging and media ads in between games, they took away the alcohol and the cigarettes that were promoted with it.
And now they've replaced it with gambling.
Yes,
Nuts.
yes. And
Yeah.
I mean, that is another addictive behavior
Yeah.
that I really feel. Good point, because I wanted to bring that up because gambling actually has very similar mental health issues and needing that recovery process the same as this in the AOD recovery plans. Gambling is very similar, and gambling can become an illness.
Yeah.
And I think there was recently in the newspaper a woman over her 60s who suddenly started gambling and started stealing off her work because she couldn't stop herself. But she'd never done anything like that in her life before, but something triggered and the addiction started. So the risky behaviors start. So I really would like to see gambling in amongst this as well because of the context of the need, the drive,
Yeah.
and the lapse and the relapse is very quick as well.
Yeah.
It's so in depth when you start to unpack how this affects society. There's so much that I think society's still learning about. And this is where it's really good that we all here have these discussions because other people have different understandings, knowledge, might have read something, might have had somebody who's experienced something. This is where it's bringing real, raw information to these courses for sure. So I do appreciate you bringing these to the table here because in the role that they would want us to be in the support, where possible, we're asking people to avoid negative people and behaviors. That's a lot to ask some people because those people are their structured friends base or family base. It's a big ask to somebody because that emotional upset, the pull away, the isolation. So then you've got to deal with that as well. So you've got to have a lot of strategies in place here for that to happen. Are there strategies that you could teach somebody who would be in an AOD service getting support, being able to still go into those same contexts and not use? So you'd have to make sure that they were very strong and resilient. Because we want the people to engage with each other, but we want for those activities to be meaningful and feeling like they're achieving. Danny?
You've got people in AOD services that don't necessarily want to be there as well, like in relation to a court order or a parenting plan, or parole kind of conditions, right?
Yeah. and everything's negative.
Mm.
Everything's the injustice of what's happened to them. And now they've been taken to an AOD, court ordered to go to a 10-step program. Or some people will choose to go to a recovery live-in service instead of going to jail. So often
Yeah.
they will see that as an option to not going to jail. But the context here is that the court is wanting you to have recovery.
Mm.
Some people are actually using that as an option to not go to jail, but not realizing the work that's going to need to be followed on with.
Mm.
And there can be barriers. There can be barriers and where support doesn't work. For some people, it won't.
Yeah, I guess looking at this kind of line of work, I'm absolutely happy to help people that are seeking help, but working with people that didn't necessarily want to be there or were mandated for some reason, I would find that so hard.
Interesting, because it makes me think of a time where I worked with a men's group that were court ordered from jail to attend a 10-step, 10-week program around behavior management. And the resentment, the not wanting to be there, I think we found a 20% rate of people coming into that group wanting to change something. The rest was resistance, still held up in the injustice of having been to prison, having charges brought against them. They haven't taken an ownership of that, so that becomes a barrier to change. But it's also accepting those people where they are at, because that's where they're at, and not judging that. And it's a tough gig. That's what I'm going to say. It's a tough gig, because you want to uphold and understand what their experience has been is very different to the next person who's willing to have change because of different ways of being. Yeah. But you are right. It's another point to make that there will be resistance in everything we do. There can be resistance in domestic and family violence. Sorry, Susan?
Oh, sorry, Danny, to interrupt.
Yeah.
Coming in on the back of you. Yeah, I was having thoughts yesterday of thinking, like, is this the right gig for me? I've always worked with young children. I don't want to be exposed to sexual violence. I don't want, and that's going to obviously happen. You know what I mean? So yeah, it's something I'm actually really thinking about myself at the moment, and seeing like family injustice, and I'm thinking, am I strong enough? Can I go through with it? Yeah, and I know it's a job that has to be done, and I'm just thinking to myself, I don't know, can I do it? Can I do it? Can I do it? And I want to do it, but yeah, I have been thinking that for the last couple of days, I have to admit.
Can I put the context for you? You're in community services, right? And we're introducing you to AOD, domestic violence, mental illness, as a general introduction to understanding, have an understanding. You're not necessarily work in that sector, but it'd be really good for you to know if you were working in a community centre in emergency relief. So you would see every walk of life come in, and people who are looking for food packages, financial support. I need to get some counselling. I need help with my children's behaviour, all those sort of things. But they might have a background of AOD. For you to have some sort of understanding what it would be like for them, those extra struggles we're talking about, those situational life events that happen, this is where this information's good. So you would be able to have a wider view of working in the context of them, of the complex issues that people would have.
Yeah, I get that.
So-
Thank you. Yeah.
So
I
when
actually really get that. Yeah.
a good rule of thumb is whenever you meet somebody, a situation, nothing is as it first appears. Because under the cover, under the layers, when they start unpacking problems and situations and they're sharing with you, more and more layers come off. And to understand when they say, look, I've got a partner with AOD issues, immediately you can have some sort of perception of what it could be, but you're not going to deal with that in the sense, but I've got a referral for you.
Yeah.
All right.
Yeah.
So use your knowledge to be able to impart to other people with. You know, we don't offer this AOD service here, but I do know of this service I can give you some resources for. And if you really want to go, we could do a referral, blah, 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 whatever your organisation allows. If you were working in a community service neighbourhood centre who had lots of resources, good understanding to know about AOD, because I've got all these local services that could support you. It opens up you to have an understanding that there's not just a general set of rules, issues that people have. And being able to give somebody informed information, informed knowledge to make a choice, that's a great thing. That's a great tool to have.
Yeah.
I don't know much about AOD, but I do know this service here is very supportive. Some of our clients have come in and said they've had some really good support and feedback from there. So would you like to have a look at that resource?
Yeah.
Job done.
Yeah. Great. Thank you.
And you haven't put yourself in that realm, so to speak.
Yeah. Yeah. But you're still engaged.
Yes, yes. And what we want to see in community services and all the different fields in community is about engagement, worker engagement with people coming into service.
Yeah. Okay. Thank you, Helen.
No worries. I think
I'll
we all
shut
deserve a
myself up.
break.
Okay.
No?
Yeah. Sounds good.
Let's
When do
have
we-
let's have a 20-minute break. So it's 7:15. So let's come back at 7:35 and we'll continue.
Thank you.
So let's begin this part with some toolbox tips. And these are tips around lapse and relapse and what we're asking people to do who are in a recovery phase around what to do when that happens. So some of the strategies that they would use in AOD services is for somebody to seek support if there's experiencing symptoms or significant changes to their mental health as well as physical health. in that recovery stage after cessation of usage. And often people take quite a few attempts to change before that can happen, and that their little lapses in that getting to that stage where they can get to the maintenance stage. So normalizing that's important. The calling upon, previous networks of people that have supported you before is very handy. So that's a resource that you're giving them. And if a person has overdosed, during that lapse or relapse, that is because understanding that what the event, the level they went back into using at the same level at their height is not what they can do now, because they've had time without it. And it affects their body so much more differently because there's a gap in time that hasn't been in their body. Making sure that they're understanding that, and understanding that this is long-term recovery. And it can be like this, very rarely like that. There's going to be some sort of bump, rise, low. Some people go like this all the time because they're still managing the strategies, the preventative measures, the changes, and balancing, it's like self-care with lifestyle changes. For people understanding what meaningful activities will mean to them takes a long while, because for somebody who's been down, and this is general rule across the board in all different areas too, when somebody's had a really low time and they're starting to build up their resilience and connecting resources and making new pathways, this is about building a positive sense of self and the self-image of where you are. So that's a big breakthrough. And when somebody can take pride in that, that means they're working towards meaningful recovery. They can develop a whole new different community by being in that different area. But it's a process. It's not guaranteed. And it is hard work, but doing something meaningful helps build up those additional strategies to minimize risk taking, to going to lapse or relapse, making sure that you're looking after your mental health. Often working closely with your GP is a good part, because if you're on certain different medications for different things that you're living with, you've got to be sure that they balance out right. The balance in your chemical makeup in your body, because you've stopped using, changes too. So that can affect medication. So you might need to lessen something or strengthen something. And this is where it's really good to ensure that people are working with their GP throughout that too. I think one of the key points is that remembering that everybody's experience is different, and everybody's dependence in some way is different. And when somebody can do some sort of achievement, that is something to celebrate and honor and promote that hope with. That's what it's about, that hope, getting on that recovery train. But as we've said, can be resistance. And often with somebody who's been court ordered to do it, is going against what they do not want to do. They want to stay doing what they've done, even though it could be against the law. They know it's risky behavior. but that's their choice. But sometimes negotiating with treatment plans and programs against their ideals, they'll often decline assistance, and you can't enforce that either, because then that would be unethical practice.
Helen?
Yeah.
Yeah, I was just going to ask you, we had, in a lecture a couple of weeks ago, we had this come up where the client was the male of the family, and you go in and like he had a drinking problem and all that sort of stuff, and then but he had kids and a wife and all that sort of stuff. So so if you're assigned a client, like now in this space, in the AOD space, do you focus, do you get what I'm saying?
Is there support for the family?
Yeah, and is that our role?
Well, if you were in an AOD service, recovery service, yes.
Yeah.
If you were full on in an AOD recovery service, families and relationships are very considered. And there's often different supports for them as well.
Yeah.
Now, the process when people go into live-in situations, the families are very much a part of the recovery process because they're their lifeline when they get out. So they go along for the process. So there's so many family sessions that you attend. There's support for the family separate. There's family gatherings and counselling. There's all these processes to walk up, to step up to the change. But yes, in that support service, even if it's a day service where people are coming in and checking in and getting support and strategies that way, they'll often have services to support families. There's groups out there that supports families as well.
Yeah. Okay. Thank you.
Because this is about supporting harm minimization too, remember? So even though a person might want to change, the family might want that to happen. So how do they cope with that? So they need support as well. So it's often there. I do know of one service that, and it's interesting because it's the Hayter Institute. And Hayter Institute has AOD detox centres around Australia. Not so much related to, it's under the same governing body, but each Hayter is owned individually, but it's all under those services. And AOD services attached to the Hayter Institute, they actually have a service where you can do live-in, and that's from 1 month to 3 month recovery plans processes. And the families are screened. There's only a certain amount of families allowed in on family day. Relationship support is done. Strategies for the people who are living or who are on the other end of relationships with somebody who's getting support. You do have a look at what they provide. Quite interesting. We actually might do an activity about that very soon. So, as a brief intervention is only brief, it is imperative that the professional is aware of the right channels for further ongoing support. This is a great opportunity for us to walk in and to explore some AOD services, but what do they actually offer? What are they offering? What is it? Only day services? Is it only counselling? Is it interventions? Is it live-in therapy with psychotherapies happening, what sort of intervention support? Has that person got a detox before they go in? There's lots of requirements that different organisations have. So I'm just going to pause there. So what can we bring back as a resource to share with everybody what you learnt about services, AOD support services in different states? So let's just go around the room. So room 1, David, Patience, and Tanika.
I was
What did you-
volunteered to speak. So I wanted to do New South Wales, being in New South Wales. And as it so happens, one of the first ones that came up other than New South Wales Health was Salvation Army. From what I could read, it was more of a inpatient service type thing, a 12-week course. But they offer it in every state. So Tanika found Mission Australia was a similar setup. So, but yeah, we were both, all three of us were sort of looking at that, and that they can offer more of an inpatient service is what Salvation Army was offering. And in New South Wales, they had, I think it was about 6 or 7 different locations throughout Sydney. So,
And what were they promoting? What were they aiming to give for that program, that 12-week program?
okay, let me go back to it. No, I've lost it. Oh, here it is. Okay. So it was about substance use. It was talking, rather than talking about it being an addiction, it was talking about it being learning how to responsibly use, or not use, but responsibly live with the substance type thing. So if they are using it responsibly. Yeah, I kind of got a bit lost now. So,
All right.
but yeah, it was a 12-week program, inpatient sort of setup. Can't find it now. Of course, can't.
That's all right. So what's the name of it again?
It was Salvation Army.
Okay. Yep.
I found it. So there's quite a few different residential rehabilitation. So it's a 12 to 16-week program. It had transitional accommodation, so it was basically what I know as inpatient. It had daily activities, the CBT, the cognitive behavior therapy.
Yes.
Yeah, it was all that kind of around that sort of offering, basically. So is that what you're looking for?
Yes, yes, I am. And especially around that transitional housing, because often people will go into these live-in rehabilitation units and have nowhere to go afterwards. Because they could either have been court ordered, they could have been homeless and they've come into a service, they could have had relationship breakdown and they're not allowed to go back to their homes, could have had a court order out on them to not go back. So transitional housing is very important here as part of that after service and stepping back out. All right, some good finds there with Mission Australia as well.
We've actually, sorry, I've scrolled a bit further and they've got withdrawal units. the residential rehabilitation. They've got what they're offering is a treatment individual for each participant through comprehensive assessment, referral, and case management support.
So now you're starting to get the language and the terminology here, that it's quite complex, isn't it?
Very.
Now, often it's really good because they actually offer a unit to detox in before going into the rehab, because you often have to have that happen before you're taken into a live-in recovery centre. And that's done separate. So it's quite complex when you start to look at it, isn't it?
Yeah, just from what Salvation Army was offering is extremely complex. So.
Very good find, a good resource for everybody, good resource for your assessments, people. Thank you.
Thank you. Thank you for the tip.
Room 3, Christine, Kavita, and Susanna popped in at the last minute.
Yeah, I'll speak. So me and Christine actually found two. One was in where I live currently, which is Adelaide, and the one that Christine suggested was at the Glen Central, at the Central Coast. So it's called the Glen. It's a rehabilitation center, and they do, as per what I've researched so far, so they do have like specifically like the Glen for Men transition program. So after the rehab, and then they do have like a 12-week residential rehabilitation program that the program actually supports clients to achieve their goals, such as like they provide them with training and education, securing them an employment, a safe accommodation and housing transition, and how to get connected back to the culture, the country, and also family restoration. Yeah. And what I found in Adelaide is called the Uniting Communities. So it's actually called they do have this program called the Roads program, where it supports the person and their family on the path to recovery. So it provides just the basic actually, which is like the counseling, but they do link them up to other services and groups within their community around the area. And they work together with them to find ways to see how they can achieve their results. And right after the rehab, they will be referred to other services, which the caseworker will work closely with them on. Yeah. So basically, this is what we spoke about. Yeah.
Yeah, definitely. Wow, great resources here. And isn't it interesting to see when you start to break down what they do, quite complex in their steps around the preparation before, the during, and the after support, which is often the most critical part, and the family support.
Yeah.
So a good understanding, this will give you everybody a good understanding of how this works in a holistic way as well. Good work. Thank you. All right, Nathan and Nathan.
I found two for Queensland. One was the Benevolent Society.
Mm-hmm.
Hold on. They deal with mental health services, addiction and recovery services, family support, early childhood services for people who like need to have help with their kids, like if they're in a domestic situation.
Yep.
There's local community programs that they get involved in to help people. That's pretty much what I've got for them. And then Nathan found one for Queensland, which was Lives Live Well, and
Yes.
they also do the same stuff. So alcohol and drug services, mental health services, youth services. There's a massive list that they do as well.
And this is all in community work as well. It's not a live-in.
Yeah, they do a lot of work for different aspects of the mental health and general.
Yes, yes. Lives Lived Well up here are very revered in the services
Yeah.
because they have proven work. That's what happens from the research that's been done about them. So that was a good find.
Thank you, Nathan.
Yeah, yeah. Good work, Nathan. All right, so but there's a whole different aspect of supporting people with AOD, living with AOD illness, that is of a community-centered based work, not a live-in, and how that can be a holistic approach as well.
Yes.
Excellent. Thank you. All righty, Viola, did you end up in a room on your own? She here? No, she mightn't be. No,
I think she was in
mightn't
with me. It's Danny.
Oh, there you are. Yeah, okay. Yep. I just saw it come up that she was on her own. It didn't show up.
I think she's popped a message in the chat as well that she had to go. Oh no, sorry, I was in the group with Vivian. Never mind.
That's all it. So what did you find?
Vivian had looked up a place in Tassie called Mission Dale. 34-bed residential on a 25-acre rural property. And says the program takes up to 6 months to complete, which I kind of thought was a really long time. And then, like you mentioned before about housing and things like that, it would completely pulling yourself out of your existing life, I guess, for a whole 6 months. It's massive.
Yeah, that's huge.
And that looks like they're a registered charity and accept donations. So we're going with that being a publicly, a funded kind of thing. And they do require people to do a medical or medically supervised detox at a different place first.
Yep, yep.
And then
can I ask, being 6 months, would part of that program be that transitional work? They're already doing it from the program and transitioning them there as well, but it'd be in the same, area, but it could be in a different room context type of thing. That
it's only a single page. So the group that run it is called City Mission, I guess is similar to Salvo's and the other ones mentioned. So their web page about it is just a single page. It doesn't have a lot of detail.
Right, okay. What's the environment look like, Danny? What did that look like? Did that look like it was peaceful, supportive? Was it in a rural area? I think you mentioned it was on acreage.
Yeah, it said, there's a link to a video that I didn't watch. Not much else. There's one photo that's just a stock photo that kind of could be anywhere. The other place we looked at was I looked up private rehab in Australia. Oh no, it was the Hayter Clinic. I thought I'd look up that one that you'd mentioned. And the first one that came up was one in Geelong. That is obviously privately funded, and one of the main differences being on their homepage that says immediate admission. They'll call you back within an hour and you can go in pretty much within 24 hours, which is completely different to anything publicly funded, where you'd expect quite a wait list. And it says the first 28 or 40 days are in a private hospital. And then they would move you for the next stage. So the first part's in Geelong, and then you go to Essendon. And the cost, if you did the 3 stages, up around $40,000.
Mm. And you still have to meet criteria to be able to go into that too.
Yeah. Yeah. It does say private health, and Medicare and things apply as well. But pretty high.
It doesn't cover a lot, and what they actually do is, I know this because we supported somebody recently to do this. Yeah, they have an avenue as part of their service is to help you access your super to be able to do this.
Wow.
Hmm.
Yeah, right.
Right. So, as long as you've got super, but it's they do have a service that can support people to do that. So, but it does cost, it certainly does cost, but less waiting time. It's run very strictly, and they do have that hospital component, the way it's all set up. But yes, it's very structured, but there's still criteria to go through. Interesting. So we're getting a broad spectrum here across the states. Thank you. Bella, John, and Sarah? Bella? Yep.
Yep.
Yeah.
Yeah.
There she is. Yep.
Me and Sarah, we just worked together. Me and Sarah was
Mhm.
group of 3 but to show up. So we were looking at about different states because we find ourselves in different states. So I don't know where is Sarah. I'm gonna talk about New South Wales. What we found there is different. It's different. It's like for the communities, like the one I have here in New South Wales, the one I searched for, and it looks after people who survived from trauma and torture. They come from different countries. They have war, they have bad life before they come in Australia. So they bring a different experience of Australian life. So when they get here, it's hard for them to settle in life in the society. So they struggle. So this one called Stats, it looks after this kind of people who comes from different backgrounds with different wounds, with different stories. So they put the community, they put them together. They organize like meetings, games, like to be socializing with others. So they have a chance to talk about what they have been through. You say which country you come from, they have people to listen to them, and then from there the community will know what's a problem with this person. So from there they find how they can help them, how they can refer, what need they have, what they need. Yeah, so this one is from the New South Wales. Yeah, it's specifically work for people who comes from different countries with trauma and torture. Yeah.
Because addictions can happen once you get here because of socialization, isolation, and not fitting in and not knowing where services are. That's a great way to have a service that can then reach out and give you resources to be able to support what you're going through. Good find. And were you with Sarah, was it?
Sarah, yeah.
Yeah, Sarah, what did you find? Not here. Okay, let's move on. Don't you?
Sorry. Oh, sorry, I was on mute.
There you are. Yeah, you are.
Sorry, I was on mute. I've been talking with my mic muted. Okay, I looked at the Victorian Department of Health. So it encompasses all the services. So there's a prevention of harm where they and there's also medically supervised injection rooms. They have treatment services which are provided in the community. And there's residential treatment services, which include rehabilitation and withdrawal services and supported accommodation for clients that need those services. And they also have hospital-based services, which provide withdrawal treatment with medical supervision 24/7 and 7 days a week.
There's quite intensive programs there.
Yes. So there's also pharmacotherapy treatment that is offered. Which is the use of medication to assist in the treatment of opioid addiction. And there's also public intoxication reform, which is a model that is used to inform stakeholders in the Victorian public about AOD awareness and prevention.
Yeah.
So that's like information. Yeah. And then there are population-specific services, which look at specific populations, like the youth, different groups, like Aboriginal groups, it's like a specialized services which provide treatment that meets the specific needs of the population. There's also forensic services to reduce harm from alcohol and other drug use and crime, and services for young people. And there's also family and peer support so that they can be helped throughout to support the people throughout their treatment and recovery. And there are also links with with other service providers within the community, within the state.
Wow. So a really connected organization that's a holistic approach that's actually using community resources. So they'd obviously have a network of support services. So anybody going into this service would have a whole array of support service to meet all the individual needs, which is amazing, which is great. What a great resource. What's the name of that again?
It's the Department of Health.
Yeah.
So they are linking with all other organizations and service providers to make sure they get access. So there's also like a link to intake. They have links to intakes where they link with the other service providers so that whoever they come in contact with and needs a referral to the health department and they need that service, they can be linked to the service.
Excellent. Well, look, some excellent resources there that everybody can tap into for your assessments here, and some good understanding of the broad perspective of the types of services that are out there. Thanks, everybody, for that. That was great work. All right, now let's get back into where we're up to. So let's have a look at, now we're talking about documentation. So when we're working with somebody, you could be in a different section like triage and screening before coming in, like an intake area with somebody coming into a service. It could be documentation around your gathering information as a case manager for somebody. And there will be plans that you work on. You look at your referral service. Straight up, always a letter to a GP is very supportive in finding out if there's anything other background work that the service needs to be understanding how to support the participant. It's about that informed knowledge. We're gathering life information and challenges that somebody's been through, what dependencies they've had, what behaviors, past behaviors, who have they accessed before to try and help them. All these
Helen,
things. Yeah.
sorry to interrupt. What if they don't have a regular GP?
That's an interesting point, because some services actually have GPs that they know of in the district that they would recommend going to, that other participants would have found quite well, or to have an understanding of the approach somebody might have to have, because a lot of people might want to go to their family GP.
Yeah.
So you can actually, often an AOD service would have the names of a couple of local GPs that are very supportive of people who are seeking assistance.
Okay. So in that case, you would, if they haven't got a referral, you would recommend them to go and see one of these practitioners. Is that right?
You'd still have to have a referral to that GP for them, right? So you could let them know that some AOD services have a connection with GPs and they have a referral process set up.
Mm.
Others would be that you could find a GP and you could support somebody to make that initial appointment. And you could be helping them link into a new GP.
Yeah.
Because often, when you go to a new GP, you've got all that paperwork to fill out. Some people might need some support with that. So you might go with them to do that, or it'll be a referral service.
Yeah. Okay, thank you.
All right. So part of the intake service is documenting and finding out what sort of supports have already been in place to ensure that some of these are followed on as well, because they might be crucial to this person's recovery and they've stopped for a stage, but they did work in the past. So it's understanding what progress they have made as well. But documenting your case management work is crucial. Each organisation will have their own policies on what to do with these and what to follow. Now, we want to talk about motivational interviewing. And this is where motivational interviewing can actually bring an understanding for people around what's been happening for them, because you can reshape things in different ways. You're talking about those goals and how you're minimizing independency, but how you're reframing that for somebody who could be in a negative frame of mind around that as well. And in chapter 3 of your learner guide, there's information around that motivational interviewing. And I'm actually going to take you to show you a demonstration of that as well. Got a recording from one of our trainers. And it talks about working from a strengths-based approach. When you're actually interviewing somebody, when you're focusing, if you're doing an intake with someone, focusing on what they did achieve before, focusing on what strengths kept them going, focusing on the supports they've already got in place. They might minimize that and go, oh no, well, I only did this and I only did that. You could find that when you start to understand what strengths people have, that's finding out about this biopsychosocial wheel, the social, emotional, and physical and environment, what's been happening for them. And you could find lots of them positives that are there for you to use to motivate them to want to change. So this is important information here. So I'm just going to stop sharing. I'm going to go and get this recording for you to watch. Now, you can access this in your assessment as well, but I thought it was a really good tool to have a look at. Motivational interviewing can be used in so many different contexts. So let me just go and get that for you. All right. I'm just going to press pause here. All right. Make sure we've got. So that resource for motivational interviewing is actually set into your assessment piece, and it's to help you with your assessment work when you're doing your role plays. So this is a great skill to have in community service work for any sort of work, motivational interviewing. It's where you can actually take somebody who's giving something a negative, turning it into a positive around how it could look different. If you could turn it around, how would it look this way? So finding those strengths and working upon it. Let me go back to share my screen. All right, so we're getting down to that part of the night where we're getting closer to assessments. We'll just have a look at these standards that are in place. There we go, get that back. So there's the national practice standards in the sector of mental health, and AOD comes under that. There's different standards that must be upheld as well. So as workers in the industry, if you're in that industry, standard 1, rights and responsibilities, safety, privacy, dignity, confidentiality, all these things that would be in your policies and procedures, ethical practices within an organisation. Standard 2 is around working with families and carers in recovery-focused ways. So as you did the research tonight, you found many services had supports for families and those close to supporting those people going in for therapy. So that's an actual national standard as well. Standard 3 is meeting diverse needs. I think Bella brought up about the service that it's actually identifying and supporting all different cultural aspects of support and being able to do referrals. And that's an important process here to meet the diverse needs of the community. Same with Standard 4, making sure that at the forefront there is support for First Nations peoples and their communities. Standard 5, access to mental health practitioners. This is a crucial part of the work that's done here. And it's all under that mental health practice standards of achieving support and safety and ensuring participants have the right access to equal access to all different types of supports here that are in the industry. Often, though, it's, as you've heard too, even the private sector, it's different again. But that's having access to funding to do that as well, which puts constraints on people's lives. There's more standards here for you to look at for the national practice standards for mental health. So in your learner guide, I think it's page 47, it's in section 3.3. These standards could be part of your questions or your tasks as well. So make sure that you understand these standards, because these are set to help have guidelines for workers in the industry. These are set to ensure people have the right to these type of services and ethical standards and practices, and to be able to move forward in recovery.
Helen, can you hear me?
Yes.
Yeah, I was just going to ask, sorry, I popped out for a couple of secs, but if you're dealing with someone like who's an immigrant, who doesn't speak English, who, you know, like, yeah. So I gather you just go through the same, all those standards as well. So you're finding someone who speaks their language, and can help them integrate and all that sort of stuff.
Yes. So definitely starting off by using an interpreter.
Yeah.
And you have a language interpreter and a cultural interpreter, two different things.
Yeah.
Language is just around exchange of those words. Culture is around understanding that different cultures will have different beliefs and practices.
Yeah.
So some cultures don't believe in mental health. They don't believe there's a mental illness.
Yeah.
So, but you can access that. And there is a national service. You'll learn this in your communications course, COM002. And there is what we call a TIS service, and it's Translator Information Service, and they have a national number, and you can either have a phone consult with an interpreter, you can have somebody come out and join a meeting, you can organise that through there. So that's called TIS.
So you would ideally have someone from the same cultural background with the same language.
You can ask for a language interpreter from that particular
culture.
Yes. So if you were talking that you needed somebody who could speak Tagalog, somebody who could speak Russian, all those different, you can ask for that and they will have interpreters for them.
Yeah. Okay. Thank you.
Okay.
Yeah.
All right. Getting to the end of tonight, just wanted to make sure everybody understands they have their resources for self-help support here for stress, or if they know somebody might need support. So let's first of all have a look at, we have some new rules for role plays at HADA. So in trying to make sure that we're meeting the Australian standards here, to meet the industry, the expectations are that you're not just reading off a script. And when the scenario does ask for another person, you can't play both people now. It was something that was happening that we did allow, but the standards have changed and they now say to meet workplace conditions, and to demonstrate that, you do need that other person to play those roles. So if the role play says there's 2 or 3 people required, that's what you need to do. You can, and I'm going to give you the link to request a role play support for that. But For those who were doing their own role plays with themselves, playing both parts, that's now going to be sent back to you as unsatisfactory because it's not meeting industry standards. So trainers can do role plays with you. If it's still needing 3 to 4 people, what they'll do is they'll put a role play request in to HADA, and they will try and gather other students who are wanting to do it too. So just for sake, CHCCCOM002 requires 3 other participants besides the main speaker. So it is a bit of a change, and this is where we can actually use class time together if we need groups to do that, to be able to organize that. So you can do it with your peers, or you can put it into a request into HADA, and I'll give you the details in a moment for that. So change up now. It's from the Australian qualifications AXPA, and they require now that to meet the standards for industry. So we're simulating what it would look like in the field, out on the job. And for somebody who's reading just off a script, can still have a script, but it's not reading, which is what we've been having. And so they went and did this, and then they did that, and then how can you tell me what's wrong with you? So some people are doing that, reading straight off a script like that. So there's no interaction, there's no communication. You can have a script there with prompt you to use, and you can look down casually to it and keep working. But for those who have been holding up a script and just speaking, they're saying that does not meet industry standards. So they want to see how you communicate, want to see how you interact, want to see how you show respect, your verbals and your non-verbals reactions. And you could have a script there, but you could look down to it, refer to it. And so then can you tell me what happened next? You could go back and look at your script. So we're going to make a referral for a GP. We have to tell you about consent, right? So you can have prompts there, but standing and reading straight off it is not going to be passing, and it will get sent back to you as unsatisfactory. So this is just bringing you up to standards of what's changing here. And this is where it's going to be good to reach out to Calendly, so you can actually do a Calendly booking yourself here, or email LSO and let them know what role play you're up to. Now, they're wanting you to be ready to do a role play when you ask for support. You've gathered all your information. You might have a script or a dot point sheet. You've done the email work that's required for the assessment. You've got a recovery plan in place if they want that. Had you had to download resources from First Access? Have you got them ready? Because when they say we've got this space available, you're ready to go. So that's your 2 links there, LSO at HADA Institute, or this is your self-help Calendly, and you can have a session with a learning support officer who can help meet your needs that way as well. Now, for the tasks in this, I wanted to also bring up. Yes, Christine?
Yeah, I just wanted to ask you, there a couple of weeks ago, I tried to do one with Vicky, and she said, look, you've already used up your hours learner support for the month, and I've got 7 role plays to do, you know? And I basically have kind of fallen behind a little bit on my role plays. So am I still just restricted to
what they
hour?
say is that
Partner
Yeah,
support?
everybody has an hour per month with a trainer, so that's
Okay.
2 half-hour sessions.
Okay.
So half an hour per fortnight.
Okay. So
so
like, for example, in the month of August, I can do 2 role plays. I can use
Yeah.
my learner support to do 2 role
Well,
plays.
I would, so your half hour should get 2 in at least. You could do 2 role plays in half an
Okay.
hour,
Fair enough. Okay.
all right?
Yeah.
The other thing that I think would be a good suggestion is that you, if it doesn't need a trainer, that you're linking up with a peer to do role plays with.
Yeah. Yeah. Well, I've already, when I did the breakout room with Kavita, I suggested that to her, but I need 2 other people to do that. Is one of the tasks that requires 3 people. So if anybody would like to join me and Kavita, just
I'll get to the end of session and
yeah.
I'll stop recording and then we can have that discussion, okay?
Okay, sorry. Okay, fair
Yeah,
enough.
yeah, no, it's
Yeah.
it's a good point, but it's a good point to bring up that we need to
Okay.
we need to
All
have
right.
groups.
Fair enough. Thanks. Cheers.
All right. So with the assessments here, task 2 role play, you conduct a role play with motivational interviewing. That's why I wanted to show you that video you watched is actually connected to the resources for this. So and it was very it was not so obvious in the task, but I was going through everything and I found it. So think about what you learned around that active listening, being non-judgmental, supportive approach around motivational interviewing. You will be working with somebody called Jack and you're doing a brief intervention and you have a template there to fill out as well around support services and what you're going to be doing to support this participant. And you have an email to do to follow on with the ongoing progression for Jack and to do an evaluation of what they've achieved. So this is looking at your processes of how you motivate somebody to make change, and you're looking at the stages of his change and what resources are appropriate for him. And then with the task 3, you have a case scenario that you are a drug and alcohol worker at First Access, and part of your role is to do brief interventions. And you are working with somebody called Layla, and somebody who's had a relapse. So you have to do a motivational interview with them to identify where they're at and what interventions you would like to bring back in because they've had a relapse. And where would you start them off at? So that motivational to get back onto working through maintenance, going to programs or your counselling support and your AOD support group or peer worker. So you're looking at appropriate interventions there for them. So I'm just going to pause there. So just once again, everybody's got at home those resources to tap into, lso@hayderinstitute.edu.au, and you're booking your own Calendly. It's there in the recording for you. Okay, take care, everyone.
Thanks, Anne.
All right, I'm just going to stop.